Good evening. I held on for a minute there because I was conscious that folk were still joining this meeting, but it is a couple of minutes past 6 now, so I think we'll just get underway. Just to really explain the purpose of the meeting, the purpose of the annual review is for us to be held to account for our performance and the way in which public money is being prioritised. I appreciate that the performance review is retrospective and that a lot more water has passed under the bridge since March 2023. But we welcome the opportunity to review our previous financial year. We'll focus on areas of success, areas of challenge, and then outline our priorities moving forward, which we hope you will see in our next annual review. The meeting format will be a presentation from myself and then an opportunity for anyone present in the meeting to ask a question of me or any of the senior management team that we have with us this evening. We also have some questions from engagement work leading up to today that we hope to be able to cover as well. Carolyn has put in the meeting chat that this session is being recorded and will be made available on our website in the following days. Therefore, if you put your camera on or ask a question, please be mindful that this will be in the public domain. Can I please ask that everyone keeps their microphone muted unless they are speaking, and when we get to the question and answer session, people raise their virtual hands or real hands if needs be, just so that we're not talking over one another. We will not be able to answer any patient-specific questions in an open meeting, but please get in touch with us outside of this if you're concerned about something you would like to have addressed. We would direct you to our website where you can find feedback and complaints, and there's also a website which you can Google called Care Opinion, and either of those are avenues whereby you can give us feedback and complaints. Okay, we'll just skip on to our 3 R's. Our 3 R's, recovery, resilience and redesign, and I think that really covers what we've been doing in the past year following the pandemic. And moving on again, we'll start to cover some of our activity. The 2022 to 2023 annual delivery plan was submitted to the Scottish Government on the 31st of July 2022. It was formally approved by the Scottish Government on the 22nd of September 2022, and this was NHS Shetland strategy to address overall priorities to cover NHS Scotland's priorities in recovering from the COVID-19 pandemic, to stabilise and then renew the services. It's probably worth noting that participation in the vaccination programme remained really high locally. A total of 9,196 individuals had a winter COVID-19 vaccination, so 78.9% of eligible residents took up our offer. Residents' participation in the campaign was again amongst the highest in Scotland, the 3rd highest rate for a territorial board in Scotland. NHS Shetland engaged with the public on 2 key strategic issues. In the past year, Public Health conducted a population health survey aiming to understand more about the health and well-being of our local communities, and this has gone into the planning and much of the work that's been done around community planning now as well. And as part of the investment appraisal process regarding the future of healthcare in the islands, a series of professional workshops were completed to inform the initial phase in our planning process on a potential healthcare campus to deliver services in the future aligned to our clinical strategy priorities. The main element of this is really looking at replacing the Gilbert Bain Hospital, and work is ongoing at the moment, as I'm sure you're aware, to install the permanent MRI scanner as well at the Gilbert Bain Hospital, and that's due for completion early next year. Okay, moving on to unscheduled and urgent care. For the first time since this statistic was introduced during the 2022-2023 year, NHS Shetland did not meet the target of discharging or admitting to a ward 95% of patients attending A&E within 4 hours over the course of the year. In 2022 to 23, our rolling average was 91.8%. Only in April 2022 was the 95% target met. In 3 months during the winter, our local performance fell below 90%. There are a number of reasons for this, and I'm happy to cover those as we go through. Moving on again, look at how we're improving the system. We've been undertaking improvement work in unscheduled and urgent pathways. We've recently embarked on a test of change with Scottish ambulance colleagues, where they call before moving a patient to the Gilbert Bain Hospital to assess if the patient can be cared for safely at home. This will hopefully help us move to less people being taken into hospital for care that can safely be provided at home by their community or Scottish ambulance colleagues. We have now implemented appropriate redirect pathways for those presenting at A&E to ensure that they are seen by the most appropriate healthcare professional, which should have a positive effect on accident emergency waiting times. And moving on again to delayed discharges. Our delayed discharge performance has decreased this year, with both an increased number of patients being delayed and the number of bed days occupied by patients medically fit for discharge. However, this is a trend seen across Scotland. We still remain the best performing health board in Scotland with the lowest rate of delayed discharges. This is as a result of the great ways of integrated working with other partners via the Health and Social Care Partnership, but most especially the Shetland Islands Council and their care services. We saw significant system pressure start pre-winter with the Health and Social Care Partnership moving to a business continuity stance around this time last year. In doing so, they established multidisciplinary teams in those localities with a health centre and care home, which were enabled to expedite discharges back into the community in a more efficient fashion. The MDTs remain in place. Moving on again to planned care. The board has not achieved the 18-week access standard from GP referral to outpatient appointment and/or treatment in Shetland over the last 5 years, averaging around 84.8% against the 90% performance standard. In 2022 to 2023, both months, 2 months, July and December, met the 90% target, with July at 91.2% being the best performance. In comparison to the prior year, 2021 to 2022, this is a slight improvement as only 1 month met the target. And just moving on again, but staying on planned care. Another important part of the meeting, the referral to treatment waiting times, is people being able to access tests and investigations quickly when they need them. This is a 6-week target attached to it. During and following the pandemic, we had significantly decreased visiting services performing some key tests, so people did have to wait longer. In 2022 to 2023, a local consultant sonographer was trained to be able to perform investigations locally and decrease our resilience on visiting services. And moving on again, but staying with planned care. We rely on our regional and national colleagues to support many of the specialties that is not realistic to have on the island. NHS Grampian is not able to sustain the obligate network arrangements that have been in place since 2008. This means that we do not have access to certain key specialties that support long-term condition management, meaning longer waits or arranging other costly visiting options to meet patient needs. National treatment centres are part of a plan to manage increased demand across all health boards. At the moment, they aren't a viable option for island boards, but we hope that they might in the future. We work closely with regional and national partners to come up with solutions for demand and capacity challenges. And moving on again, but staying with planned care. We've continued to invest to make repatriation services to NHS Shetland a high priority in 2022 to 23 to move services closer to home. In addition, part of our COVID-19 transmission prevention management strategy has been to minimise patient travel to the mainland for care and treatment that could be provided locally. Not only has this saved a significant amount of money, but more importantly has reduced across 13 different pathways around 2,588 patients time back from not having to go off Shetland for treatment. During 2022 to 23, the latest development at the Gilbert Bain Hospital was the completion of the ambulatory care project. This new facility opened in September 2022 and provides a 12-bedded unit. It will increase local capacity to deliver same-day surgical and ambulatory care to patients. Our teams have worked hard to improve pathways and deliver high-quality care as efficiently as possible. For example, managing 18 cataract operations per day and meeting our activity forecast, meaning we're planning resources well. Patient-initiated follow-up or review is another way of working more efficiently, saving patients time by them attending, not having to attend when they don't need to, and making sure that they are seen when they do. This kind of work means that people who are in most need of services are better able to access what they need. And moving on, if I can, to cancer activity. We still have a sustained cancer activity and have configured our services to ensure these are dealt with in as efficient a manner as possible. This will include links into Grampian when necessary, and you can see we have an average 70 to 90 patients at any time on a 62-day pathway, which is the pathway from receipt of referral to the start of treatment. We've seen a decrease in performance in this pathway, primarily because for a lot of patients, this pathway is dependent on elements of diagnostics or care being provided in NHS Grampian, and their system is also under considerable pressure at the moment. Once a decision has been made to treat, the treatment starts within the 31-day target in 100% of cases. Moving on, but staying with cancer again. As I've said previously, our links into NHS Grampian mean that their challenges become our challenges. We know that there are longer waiting times for diagnostics, as well as with the interpretation of medical imaging to help inform treatment plans. Also, their system pressure is having an effect on the theatre capacity for surgery, as well as radiotherapy and chemotherapy initiation. This is coupled with the long distance our patients have to travel to Aberdeen or beyond. Travel is often affected by weather or technical issues, which puts additional stress and pressure on our patients. The fact that we have no early morning flight at present means that we have to fly patients who have an appointment before 11 AM down the night before and accommodate them, which means additional time away from home and support networks at what can be a stressful time. The distance also means that our patients are often unable to take up the offer of short notice appointments due to capacity on air routes or on the ferry. Moving on, if I can, to mental health. Mental health is a big priority for us in Shetland. We want to improve access to appropriate services, as well as supporting good mental health and well-being for everyone, including our staff. Two of the national targets that we are measured against are for access to CAMS, that's child and adolescent mental health services, and access to psychological therapies. CAMS have made some changes to improve support and access. They've expanded to provide for 0 to 18-year-olds rather than just 16 to 18-year-olds. FT to decrease inequality and improve experience and outcomes. They've seen an increase in the need for specialist support, neurodevelopmental and learning disabilities particularly. The team do multi-agency vetting and triage of referrals to make sure people are seen in the right place by the right person the first time, and they're working with different services who work with children, young people and families to maximise use of tier provision, including education, social work, third sector provision. To manage the increased demand and need seen, the team have set up assessment clinics and group support for families. Small teams mean the service is vulnerable to absence, planned and unplanned, and the need for certain specialist input can delay access, e.g. waiting for a visiting specialist. The team is making a lot of use of remote access options to support children and young people in ways that suit them, and also looking at family and carer support where appropriate. Staying with mental health, moving on to psychological therapies, the team have worked really hard over the last couple of years to make the services more stable and increase capacity. In 2022 to 2023, the psychological therapies team added group options for support, used digital and remote options for support, and were successful in recruiting to their psychological therapist posts to offer more first-line support for people who needed it. All of those changes has meant that the team has been able to see more people more consistently, and there have also been more referrals coming in. The team saw nearly 200 new patients in 2022 to 23, compared to 160 the prior year and 105 the year before that. Again, the small team means that they're very vulnerable to planned and unplanned absences, and we often see performance vary. It has been really positive to see over the past few years that while we are not meeting the target, that the national targets, we are continually improving, even with increased numbers of referrals. Staying with mental health and looking more so at the challenges. Mental health isn't just about psychological therapies and CAMs, although that is what the targets focus on. Our mental health team provides services to lots of different people for lots of different reasons and conditions. All our models of care are community-based support and treatment across services. However, due to our geography, the ask is much wider than this in Shetland, and we provide much more than community mental health services, which often spread staff thinly, especially when crisis intervention is required, for example, supporting somebody in hospital. All our professionals have to have generalist skills due to the wide range of presentations to the mental health team, and this can have an effect on recruitment. When crisis does occur, it often means local crisis intervention followed by the necessity to move to higher levels of care on mainland Scotland. Where possible, the team have expanded their ability to undertake home treatment. We have specialist input into mental health pathways, which include assessment, treatment and support for many different areas, such as eating disorders, substance use, neurodiversity. Recruitment and retention of staff is not just a Shetland issue, but also a national issue, and this is compounded in Shetland by smaller teams doing work in several services. Excuse me. Community mental health is a community team that supports people in crisis and during periods of acute admissions as well as through home treatment. The team often have to provide treatment and support to a population group that are widely spread over the main island as well as the outlying islands. Increasing demand in services in terms of work, service provision and referrals. In terms of the daytime work as well as sustaining the out-of-hours service. Moving on to development, mental health development. Real success is found in the difference we make in the lives of people who live in Shetland. We have achieved national firsts in terms of treatments for substance use and had work recognised at a national level. As mentioned, we have an increased provision of home treatment across mental health services, and notably for people with diagnosed mental health conditions. We have a low number of people with dementia in acute settings due to treatment, support and dedication of staff in their mental health service. Continuing on development, many of the changes we make improve outcomes, but also improve the sustainability or resilience of our services. This is important for patients and teams. And proven resilience can be by adding in regional networks of support or by working in different ways. We have introduced group work across psychological services, which has reduced waiting times and meant that people who are referred get access to the right support sooner. Our teams work with their colleagues to ensure people who may have long and enduring mental health conditions have the same access as everyone else to other services and care. And moving on again to other challenges. Whilst our absence rate is one of the lowest in Scotland, our staff turnover rate is one of the highest. The reason for this is multifactorial. Our location and associated costs of getting on and off Shetland means people often do not stay. The number of fixed term contracts we use to fund to the funding resources not being given year after year. This is also the fact that people come here for development and professional growth opportunities and then move on after they've acquired these skills. Staying with workforce, some of these solutions are shorter term while we are using some of these solutions are short term while we make our services more sustainable. For example, grow your own options included in nursing and children's nursing, and service redesign offering more advanced practice roles, more healthcare support worker roles, for example, in community nursing and dietetics. These solutions mean that our clinical time goes further and we can have more stability and support within teams with people developing skills and responsibilities. This is sometimes called skills mix when we are talking about improvement projects. The training options have meant we can recruit more people who are likely to stay in Shetland, but for whom moving away to train or study is not an option. And in terms of agency being approved at a high level to make sure it's essential and keeping on top of spend, we've agency locums, 4 acute nurses, 3 CPNs, 1 ODP, 1 substance misuse nurse, 1 OT, 1 psychiatrist, 1 biomedical student, and we're awaiting an audiologist and a pharmacist currently. Moving on to dentistry, if I might. Routinely, NHS dentistry all but closed down during the pandemic, and this caused the large backlog in dental problems and waiting lists. During this time, an increasing number of dentists did not return into NHS dentistry, which has exacerbated the problem. The dental workforce has declined in numbers as a result of the pandemic, Brexit, and the number of dentists working outside of the NHS. In Shetland, we have one independent practice that is back to doing about 50% of the NHS work they were doing pre-pandemic. In the public dental health service, we have gaps of 2 whole-time equivalent dentists, and that's impacting on the access that we can provide. Staying on dentistry, a recently approved oral health strategy will look at bringing more NHS work in-house to be provided by the public dental service. Our dental director is currently in discussion about the required funding to bring this to fruition. The public dental service budget from the Scottish Government has not risen enough to do this out with, without financial additionality, and we are currently trying to recruit dentists into our workforce to increase the amount of activity that we can undertake. We recently had a successful trial of final year dental students from the University of Dundee spending some time in their public dental services. We know from other training pathways that if we sow the seed, we can reap the benefits in future. Okay, happy to take any questions or comments at this stage. And again, if you just want to raise your virtual hand or wave if you can't find that. I'm not seeing any hands going up or any comments, but did have a couple of questions that came in ahead of the session this evening. The first of those asked, the latest annual accounts indicate that the Health Board is struggling to retain staff. Touched on that in the presentation. 19% of the workforce left their jobs over the year. And it asks how much of this is to do with the lack of available housing in Shetland. Are new recruits leaving after struggling to find somewhere nice to live? What is the Health Board doing about it? There was talk of including accommodation in the new Health and Social Care campus. Have these plans been developed any further? Is there any scope to provide other housing in the short term? There's quite a lot in there. Would somebody like to take that question? Three hands gone up at once. Let me see. Brian, you were first, and then I'll come to Kathleen and Lorraine.
Thanks, Gary. I see Lorraine has put her hand up, so she might come in round about the specifics of why we've got a high churn and turnover rate from an HR perspective. But on the accommodation front, we're well engaged with council colleagues and other housing association kind of colleagues round about accommodation and how difficult the perception is to get accommodation on coming to Shetland. So we have taken some board decisions round about procuring Scottish Government finance to purchase some additional accommodation to facilitate people coming up. The problem is often around about family accommodation rather than just single person accommodation, and that is some of the challenge round about getting accommodation that's appropriate for the size of family that might be moving up, but also in a locality that suits the needs of a family as well. So I'm sure that there are challenges that every employer will face when they're bringing people on island, but we are engaged with other stakeholders and partners around about how we can alleviate some of these challenges moving forward.
Thank you for that, Brian. I'll come to Kathleen next and then Lorraine. Kathleen.
Thank you. Just to build on the points that Brian has raised and to address part of the question that you asked. So as part of the work to develop the Health and Social Care campus, one of the work streams is looking at residential accommodation for key workers. So what we've been doing over the last 12 months is having a look at, as Brian noted, the accommodation that we have available to us. We've been improving some of the policies that we've got around how we use our own accommodation. And in the exit survey that all staff are asked when they leave the organisation, we've added in a specific question about whether accommodation was a driving factor in that decision. So we're gathering better information, if you like, about people's reasons for leaving. We intend to have our residential accommodation strategy for key workers brought to the board probably in spring next year. So at this point, we're data gathering. So as the person who asked the question had intimated, yes, we are looking at that as part of the Health and Care campus. But what we're trying to do at the moment is focus on what accommodation do we have available to us, because we won't have a new campus for some time. So the things that we're doing also includes how do we maximise using the accommodation that we've got efficiently. And I'm sure Lorraine's got more information about what that means in terms of, the points in the question about why staff might leave and is accommodation a driving factor.
Thank you, Kathleen. I'll just go over to Lorraine.
Thank you, Gary. Thank you, colleagues. And just to add to that, so I think as per the chairman's slide set, we know that people leave for a whole multiple reasons and rationale, including the ending of COVID funding, where we took on additional staff to help support in terms of the pandemic. We also get a lot of what we call non-recurring funding from Scottish Government. So we have a a disproportionate number of staff that come on a fixed term basis, and at the end of that period or leading up to that period where we might not have that funding ongoing, or where staff are making choices about their future, we lose those staff and they leave. We also, in terms of our workforce, the same as in terms of our community, we have a number of staff that are at retirement age. So again, we lose staff for retirement. Over 40% of our workforce are currently 50 plus. So again, you know, in terms of that aging workforce, staff will leave. And I think one of the kind of success factors of Shetland is that we are an absolutely outstanding training organisation. So in terms of our student population, in terms of colleagues joining us, they tend to get a really good developmental experience, and we have a relatively flat structure. So again, a significant number of colleagues move from us to different portfolios within different health boards. And I think that we are always, as a board, going to welcome colleagues coming, spending time with us, sharing their expertise and their skills, but growing and developing and moving on to a career, even if that is out with Shetland. I think pragmatically, we have to understand that Shetland is not necessarily home for all of people's work lives. And again, a number of colleagues come and join us, but they have family elsewhere. And again, you know, colleagues leave because their commitments elsewhere mean that they have to leave the island to potentially maybe look after relatives. So there's a number of things that, as Kathleen mentioned, in terms of our exit analysis that come from that. We are currently, as Kathleen says, reviewing our exit analysis way of doing things so that we can capture much more information in real time, including an element around about how we retain staff. So again, we really want to understand how we can retain as many staff as we possibly can, but being really pragmatic that there are push and pull factors. What we know from the exit information is that we don't have a lot of staff leave because of accommodation. That's not the number one thing that they are putting in that analysis. But again, asking the question much more upfront may prove different. But what we are understanding from an attraction perspective, and bearing in mind, whilst we have staff leave in the same period, we took on 102 new people into Shetland and into roles, along with having a number of internal transfers to promoted posts, is that the reality of new joiners coming to Shetland, they are finding accommodation quite difficult. And again, it's around about what you and or your family may be looking for. And what colleagues have said, because from a recruitment perspective, we do try to follow up on that, is that sometimes social media is not helping. So where colleagues are putting out, coming to Shetland, looking for accommodation, there is some negative comments that might not be as helpful as they could be. So again, we're trying to do everything that we can, understand some of the reasons, but also working with colleagues, with agencies, with providers around what we can do in that arena. Thank you.
Thanks, Lorraine. I've got two more hands up. I'll bring in Lucy first.
Thank you. I was just going to come in kind of on the same point in the thinking about the bigger picture, just adding to what Lorraine and Kathleen had said, that housing for key workers is a part of the local housing strategy from a council point of view, and we're really engaged in that work with partners, certainly through the Shetland Partnership Plan, looking at how growth in Shetland generally, of how we make the, because we're not the only ones with this problem, and there's a limitation to how much we can do. So as Kathleen was saying, the kind of idea of accommodation within a health campus is a long way out, and it's also limited in size and how realistic the kind of what we can house within that. But that kind of engagement with the Shetland Partnership, when we're looking at Shetland as a whole and what does Shetland need to be able to attract people, is where there's kind of energy focused, and it's really hopefully going to make a difference in kind of coming years as well.
Yeah, I think probably also worth noting that we did buy, I think, a 10-bed accommodation in 22-23 as well. which has maybe helped us out with some of our short-term accommodation needs, at least, especially for visiting clinicians and the like. I've got a couple more hands gone up. Marie Manson first, and then I'll come to Gary Docherty. Marie?
Hello, I'm for Shetland Science, and firstly I'd like to thank the NHS for getting the Northern Star bereavement suite built, and I was delighted to be able to open it last Monday. This will bring so much comfort to a lot of folk that's going through baby loss in Shetland. One of the things that I spoke about at the opening was that a lot of folk out to travel for Shetland to Aberdeen if there's something happened to their baby before they're delivered. And sometimes they go on a commercial flight rather as our ambulance. And a thing that was brought up to us was the fact that you're sitting in Stoneborough Airport with folk at your teen, you're going through something pretty traumatic, and you're in the middle of everybody, you're not able to go away with folk. So one of the things that I would like it to gotten there is like a quiet room for folk to go in, so that they're not sitting with the general public kind of away for your body. It is being spoken about with the airport as well, but I wondered if it was something that the NHS could support as well.
That sounds reasonable to me. I don't know, Kathleen, do you want to say anything about that?
Yes, thank you, Gary, and thanks, Marie, for raising that point. We absolutely would want to support you in those conversations. As you described when you came to the Northern Star opening last week and opened it for us, you know, having a quiet space is really important and part of that pathway, and something that, you know, women and families will remember as being either a good or a bad experience. And we would really want to support you in looking at ways in which we could have that kind of facility at the airport in the future. So very happy to discuss it offline with the midwifery team to see how we can get around that issue with you.
Thank you.
Yep. Yeah, and happy to engage with Highlands and Islands airports as well to see if we can make that happen.
Thank you. That's really good.
Yeah. Okay. Gary, I've got you next.
Yeah, it was just to kind of expand a little bit on what Lorraine was saying and some of the other colleagues there, Brian and Kathleen. In the Learning Disability Service, we've encouraged learning disability student nurses to come in the last 18 months to Shetland with the whole aim that increases our visibility in terms of recruitment. I've also kind of been doing talks at Edinburgh and Napier and Glasgow Cali, and also writing papers about remote and rural location learning disability nursing. And what I've found is the response has been exceptional, which I'm hoping will eventually result in us getting more people coming to do learning disability nursing in Shetland. But it's been really helpful having the nurses' residence as well. That's gave people an opportunity to come and stay here for what are quite long placements. It's, I think we've had an 11-week placement and a 12-week placement. And I think that's been really helpful as well, because hopefully that will give us better results in the long term of, you know, it takes too long to grow our own at this point in time. But that's an option for the long-term strategy. But at this point, if we can encourage people to come and do placements here, and they've got that accommodation, which is currently at Montfield and Brewick, it's definitely helpful for me in selling people to come to a remote and rural location. So it's just to say that's a very positive for NHS Shetland that they've been giving us that opportunity as well.
Yeah, thanks, Gary. I don't think there's any doubt that having more accommodation would ultimately help us. Maria, you want to come back in? Yeah, on you go.
Yeah, I just had one more thing. SANS provides bereavement training for employers and supervisors and managers, and it's how to look after parents that's come back to work, parents and their families, on how they're when they come back to work after baby loss. I wonder if that's something that the NHS would be interested in doing for their managers. That would be a trainer that came up for South that would do it for any companies or anybody. There's nobody in Shetland yet done the training. It'd be good to get maybe the NHS to start it.
Yeah, that's a good point. I'll maybe go to Brian for that one.
Yeah, I think that really aligns to just where we're trying to get our organisation to, being a compassionate, kind, and a trauma-informed kind of organisation as well. So I think I would really welcome that kind of connection, that we can maybe move forward and organise something for managers and staff. I think right across the piece, because it's not just managers. I think it's also the big teams that we have. If staff are also appreciative, taking that kind of informed approach about supporting people and understanding and meeting them where they are, both in their professional kind of background and their professional work lives. I think that would be really positive. So yeah, again, like Kathleen, maybe that's something we can take offline, Marie, and develop into a bit of a plan. Thanks.
Thank you. That's really good. Thanks.
Yeah, thanks, Brian. Definitely fully support that. Colin Marsland.
Hi. Hi, I'm currently seem to be working with some strategy, but SANS are coming up to do a training course for the maternity staff and the children's staff. It's currently booked, so we're already tied in with them, and they're doing it up shortly for your information.
Yeah, that's I'm actually at that training as well, so it's a different training course that they're putting on. This is bereavement in the workplace, the kind of might what the training is that they're coming up to do, so that it's good that they're coming up already.
There's a whole load of courses. There's a whole load of courses that they're doing in conjunction with NHS, because the Scottish Government's given them some funding a couple of years ago for some posts in Scotland, which they're working around. Our colleagues in Grampian were one of the leading trial posts that they use for that and the developing skills.
Thanks, Colin. I'll put you in the spot here. Do you have any idea how many are signed up for that?
It's the whole of the maternity service and the whole of child health that are signed up for the course.
Yeah.
About 30 people.
Yeah. Okay. Thank you. I don't see any more hands up. Do we have any other questions at this stage or any comments? I have a few more questions on the list here that I can go back to until we see if we have any more inspiration by way of questions. The second question that I've got here is probably quite aligned to the first one, and that's just on it says on the subject of the new health centre, health and social care campus, is there any update in the timetable for this or the costs? How certain is it that the Scottish Government will provide the funding, and what has to happen next? I'll maybe kick off on that, and then I'm sure others will be able to join in. But I think, as has already been mentioned, we expect a report to come back to the board, I think early next year, with the outcome of the investment appraisal. And once that's been approved by the board, that'll be passed over to the Scottish Government. And there is a decision point there, as there is at each step of this process. I think this is memory serves me right, I think this is the third step in the process, and there are a further two to go before you can put a spade in the ground. So after the investment appraisal, there's a decision point for the Scottish Government, and then after that there's the outline business case, a further decision point, and then the full business case. So we've a way to go. So there isn't a timetable as such, beyond the fact that we know we need to complete the the current piece of work and present that to the board next year. The costs, I'm not sure. Kathleen, you're closer to this than me. I know we saw a cost previously. I'm not sure if that's been revised since. Can I pass over to you?
Thanks, Gary. Yes, we don't have figures that have been updated on the cost of the whole project at this stage. And as you say, we will be bringing a paper to board in December to set out what the timeline will be for the development of the programme initial agreement, which is the precursor to the business case. Since we started this piece of work in 2021-22, then Scottish Government has been developing its own guidance around capital business cases, which is yet to be published. But what we do know is that there are some additional pieces of work that we need to do as part of that precursor business case, which means it will take us longer. So, that includes some of the points that we mentioned earlier about understanding our residential accommodation needs, for instance, and also having a short-term plan, being really clear about what status quo means is really important within the business case as well. So as you described, paper to board in December, and then the programme initial agreement, which is the precursor business case, that will come to board in the tail end of 24-25. But, the precise costs of what a new campus would look like, or any other capital requirements, because this isn't just a single project now, this is about looking at our capital requirements for the next 20 years, will be reflected in this precursor business case. So we've got roughly 12 months to go before we're at that point where we've got all of that data together.
Thanks, Kathleen. I think that's really helpful in spelling out just where we're at. Okay, I've not seen any more hands going up. Do we have any more questions, or shall I keep going on my list? No, nothing more. I'll carry on down my list. The next question I had, and we've touched on this already, is around what is the board doing to improve access to dental care. I'll maybe put Anthony on the spot for this one, can I?
Sure. Yes, thanks, Gary.
Thanks.
So I appreciate your inclusion of the details in your presentation. That was very helpful. As presented and gladly approved at the last IJB and board meetings, we've taken a different approach to or certainly a proposal to change the dental service provision on island to make sure that we have a little bit more in-house control, as you said. Currently, we're in a slightly strange position at the moment. There's lots of plate spinning, and very multifactorial approach is actually looking to expand and improve the service. But the funding aspect is quite central to this from the perspective of, as I outlined in the Oral Health Strategy report, we have essentially found a reduction in our service in real terms because of the way that the dental services are provided, both centrally and from our board allocations. So we need to have a look at that from the point of view that a lot of the plans, and some are very close to coming to fruition, are not derailed by the fact that there's just not quite the budget there, and that's a historical problem that we have from the point of view of just the budget not being upkept from mainly that affects all the other boards as well. The public central dental service budget has not really been increased in line with any of the inflationary rises or the agenda for change rises that we've had to assume. So that's made it quite difficult. So I mean, we're at a tipping point at the moment, looking for the ability to have some long-term security with the budget. We do have some underwritten funding from the government, but that's not non-recurring funding. But in order to make sure that a lot of the irons in the fire, if you like, are ready to strike, we want to make sure that budget is ready. So I'm fairly sure that we're going to have an increase in the amount of dentists within our service within 2024, probably to get us back to pre-COVID levels, and that will give us a good foundation to build. It's very general, Gary. So if you need anything else, let me know.
Yeah, no, that was very helpful, Anthony. I think it covered off the question that was asked. I've got Joe wanting to come in as well, please.
Thank you. Thanks, Gary. I think Anthony's explained the plans really well in terms of what they're trying to do, and to tackle this really, really difficult position that Shetland is in regarding dental provision. And I suppose it's just thinking about, although the question didn't necessarily ask this, it's really thinking about how we engage with the public over this, because from an individual's point of view, all they're wondering is, how do I get to see a dentist? And when you've got things wrong with your teeth, that's the things that really bother you. And what will happen? Is it going to get much worse if I don't? How long can I leave it before it really deteriorates? And I think there's probably quite a lot of fear out there as well about dental health and what happens if you don't get to see a dentist. I know that Anthony and the dental service did a sort of mail drop right across Shetland a few months ago, and that was really helpful to try and give people a bit more information about what they could do, what signs to look out for, and what they could do themselves, and that kind of thing. But there's something about recognising that people only take in that information when they're ready to take in that information. So I do wonder if that's something we can do a bit more of around how do we keep in touch with the public around oral health? How do we try and encourage people to know what to look for? It is probably more education about how to look after your teeth. I think we're all just very, very used to rolling up to the dentist every 6 months and doing what you're told. And there's something about self-care that we could move towards that might relieve a bit of pressure on everybody and help to relieve the public's anxieties as well. So just some things to think about.
Yeah. Brushing twice a day, flossing and cutting down on sugary sweets.
Oh, you've got the message, Gary. Good stuff. No, that's a very good point, actually, Joe. If I just come in again here, because a lot of dental health issues are preventable. So prevention is hugely important to the message we're trying to get across. And there is one or two initiatives, we've got a very enthusiastic, proactive team that are working on that constantly. We had a drop-in clinic for oral cancer checks over the last couple of weeks, and that's been very popular from the point of view of patients coming in. But again, it's a nice opportunity to engage with the public, but it's the same concerns they've got. It's the routine care, and you're right, we're all very used to coming and being seen regularly, more so probably than a lot of other medical specialties. So we don't want to lose that momentum.
Yeah, thanks both of you. I've got Katrina Waddington wanting to come in next.
Hi, thanks very much, Gary, and thanks very much for organising this online session. It's a really good idea. Now, talking of prevention, I wanted to ask about audiology, because the situation at the moment is that people who are being referred to audiology are being told that there's no idea of when the date could be. It's not in the foreseeable future. And I acknowledge what you said about the appointment of an audiologist, and that's really good news. But it is a really worrying situation, and really because hearing treatment is an important preventive strategy. It's well documented. It's especially for elderly people, it's kind of preventing isolation and a sort of general decline, and it's also important for the path of dementia in individuals. So I'm just wondering, other health boards have started doing referrals to Specsavers, to deal with backlogs, and I'm just wondering if something like this is possible to catch up, because people waiting long periods for a basic hearing assessment is detrimental to their overall health.
Yeah, thanks, Katrina. I think that's a really good question, and it's something that I've been discussing fairly frequently with Brian since I think we had an audiologist leave us a short time ago. That's added pressure into the system. But Kathleen, do you want to pick up on that?
Yes, thank you. I suppose in terms of the current situation, we don't have a residential audiologist, but we do have an assistant practitioner who supports the audiology service. So there's lots of audiology support that's still available on the island. So the points that Katrina raised about supporting old people, that's something that the assistant practitioner does do. We're also able to provide urgent care in conjunction with NHS Grampian. And what will be different about the new service in January than the one that we've had in the past is that the audiologist will be residential. So she will be working full time in Shetland, whereas for the last few years, we've had an audiologist who's essentially been providing a good, but albeit visiting service. So a lot of things that she's been doing have been batching appointments, so people have waited longer to see her, and she's been quite limited in the things that she can do remotely. So we're quite confident that by having somebody who's working here full time, we will be able to get on top of the backlog. But we recognise it's a gap. That's why as soon as we were able to, we went out to recruitment. We've been successful. But we do have an assistant practitioner who's able to do a range of things. So if there's more that we can do and should be doing about promoting the services that are currently available, then that's something that we can take away from the question that Katrina raised.
Yeah, thanks, Kathleen. Is that a fulsome enough answer for you, Katrina?
Yes, I mean, I do take the point that things will get better and that the on-island appointment is really good news, but the fact is there are people at the moment who are not getting dates, and yeah, so it's all very well to say that people are being taken care of, but there are people who are not seeing the audiologist, and I just think you need to keep a very close eye on that, as I'm sure you will.
Yeah, thank you, Katrina. I have somebody that asks me fairly frequently about waiting times and the like, so it's not something that's going to get away from us in any way. Are there any other questions online at this point? I have a few more I can run through if not, and the next one that I had again was just touching on staffing that we discussed earlier, and it just says staffing seems to be a problem in lots of areas, including the one we've just been speaking about. Although, as Kathleen says, we've recruited there. We see the high cost of locum and agency staff. What is being done about it nationally and locally? Again, this is probably one that Lorraine can maybe just give us a little bit more on. Oh, I see Joe's hand gone up. Joe, do you want to go first? No.
I can go first. Yes, no, that's fine. So I was just going to give an example of some of the things we're doing in mental health, for example, which is to start looking at recruiting to different posts. So trying to attract band 5s back into the service and ensuring that they've got really, really good supervision structures in place so that they only are working with band 5 level cases and don't get frightened out of the service as has potentially happened before, and having that career structure where you can attract sort of trainee or newly qualified people into the service, and then support them through a variety of different grades, and just ensure that they've got that appropriate support around them, and that we really look after them and sort of nurture them. I hope will result in people in having a far more solid foundation to our mental health services going forward. So that's just one example. Thank you.
Yeah, thanks, Joe. Lorraine?
Thank you, Gary. Thanks for that, Jo. So obviously in that space, when we have a vacancy, all managers and directors are really looking at what that vacancy is, and if it's going to be a hard to fill vacancy, and by hard to fill, I mean that there is just not the numbers within the system nationally and even internationally in terms of for specific roles and specific groups. So again, we're kind of looking at what we can do and how we might be able to do that. We're looking in terms of how we advertise and where we advertise. So again, in terms of, do we need specific type of kind of headhunters to actually look at the market? We're looking at how we grow our young workforce, modern apprentices, our international recruitment programme, our retire and return scheme, other schemes that we have in terms of the GP Joy, etc. So we're really looking at that in a kind of really holistic way. We're working across the north of Scotland from a regional perspective around about how we create a kind of brand identity. And again, that's really selling what it looks and feels like to work in the north. So again, there's something around about how we position ourselves with our colleagues that are maybe more on the mainland and more central belt. So again, we're doing that. We're looking in terms of our, I suppose, what we would call our pastoral support. So how we actually support individuals that come to us, that again, it might be their first employment, might be their first professional employment upon potential graduation, or it might just mean that actually living and working in Shetland is a very different environment and feels very different for them. So how they feel supported and connected and part of a community. We're really looking at our iMatter output. So our iMatter output is our annualised staff survey, where well over 80% of all of our teams, all of our staff within teams said that their team was a really good place to work. And it was really constructive and they felt supported. So again, around about looking at how we get teams to help support us as part of that advert. So what does it feel like to work in a particular department? What will you experience and how will you be supported? So again, it's trying to take a much more holistic approach to it. Thank you.
Thanks, Lorraine. I think it's worthwhile acknowledging the support that we get from Promote Shetland as well, in terms of the information that they can provide for people looking to move to Shetland for work. Although the biggest challenge, as we mentioned earlier, is very often around finding accommodation. Brian, you're wanting to come in.
Thanks, Gary. And just to add on to what Lorraine's been saying, you know, we've also really sort of focused on that grow your own element, and really been, whilst it will take time, as you know, as Joe's touched on as well, round about developing careers and developing people into careers. You know, we've got to start somewhere, and by engaging the workforce as soon as possible, you know, it starts to then sow a bit of an ethos round about our organisation being you know, one that nurtures people, that looks after people and grows careers within Shetland. And I know there's been some really good work done in this week with nursing teams and midwifery teams being working with school-aged children to sort of show them what a career in nursing and midwifery is like, and then putting that Shetland sort of aspect on it as well, and how important those kind of sustaining a lot of those roles are. So I think that's maybe a little bit more of a vigorous change of tack that we've taken in the last few months, is really starting to engage with how do we grow our own, what does the workforce need to rebalance itself, how long is that going to take, when do we need to start engaging with schools, and how do we get work experience back up and running post-pandemic and make it really good value for the younger people to come and see what we do within our organisation. And it's also not just about you know, clinical kind of portfolios as well. When we did the Developing Young Workforce Careers Fair in Clickerman, we had a really good kind of turnout from our facilities management, our states teams, and our support services as well. And what we were discussing at that is we often find people come into some of these services just to really dip their toe into what the NHS is about, and a lot of them often then go on to do a development course, maybe in nursing or something clinical, as you know, that then brings them into sort of the clinical aspects as well. So I think it's now we're realizing what, you know, as long as we're getting people in the door, then if we have that real ethos of developing people and really nurturing them, that hopefully it will you know, prove to be beneficial a lot further down the line. Because if we look at the time span we've been using agency staff and locum staff, and the time span we'll probably always have to do that. We have to start somewhere, and I think we're in a good place now that we've really reinvigorated that kind of grow your own ethos, and hopefully that will bear fruits moving forward with respect to agency and locum utility. Thanks.
Thank you, Brian. And I see Kirsty, you want to come in as well.
Yeah, thanks. I just suppose from a medical point of view, seeing as medical staff probably the most expensive, just to sort of say a few words about what the teams have been doing over the last year, and or more than that, in terms of trying to attract people to come and work locally. And it's really difficult because there aren't enough doctors in the UK, but we've had great success of working to develop rotational posts. So these are posts whereby people come for a period of time through the year and they're not here all the time. And that puts pressure on our accommodation still, but it means that those people are able to come and work in Shetland, as well as being able to sustain their skills by working in other places as well. So we've had really good success, particularly Obs and Gynae is one team, and some of the general physicians are employed in that way, as well as some of our GP colleagues, particularly around the outer aisles where they have to perhaps work 24/7 in some instances. So that's been a real success. And I suppose just kind of following on from that, looking at how we've developed the surgical team. So this is a team that's really stable, but there will be some changes coming up, and in order to try and help maintain that team without having lots of locums coming in, we've worked with them to find jobs that have met their needs, and that's the current cohort as well as those coming behind them. And a lot of people are looking to give some time to global health. So many of our medics, GPs and surgeons donate their own time to work overseas, and that's really important to them, and we benefit from that as well. So we're working with them on flexible contracts to be able to maintain some of those interests as well.
Thanks, Kirsty. And the flexible contracts, those are NHS contracts, just to be clear about that as well. So it's not locum contracts. So that's beneficial both to the GPs and to the board, essentially. Yeah. Okay, I don't see any other hands up. I have a couple more questions on my list, and then I promised I would have a sort of look forward to the future. So I'll go to these two questions. I think they're fairly quick, should be fairly straightforward anyway. The first of which is, why is Ask My GP used in some GP practices and not others? Who wants to pick up that one? Joe?
I'll maybe ask Tony McTavish to come in just after me, but it's just to say that the reason it was rolled out initially is to the bigger practices, as we were advised it kind of worked better with larger numbers of people, and that it would be quite difficult to manage in smaller practices. Having said that, we do think as we move forward with trying to get the practices to work even more as a network across Shetland and less as individual practices, that there may be ways of gathering together the people to form a big enough number that it does start to work better in those smaller practices as well. I think some of the challenges we've had is that it's a really good tool that was introduced quite quickly during COVID. And we didn't, just because of the pressure on staff at the time, we didn't really probably alter our practices to work as well with Ask My GP as we could have done. So that's some of the work that's going on now to look at how practices need to alter to enable Ask My GP to be to kind of realise its full potential, I suppose. But I think Tony would probably have more information than I do as well.
Thanks, Joe. Tony, do you want to come in?
Thanks, Joe. Thanks, Gary. So yes, Joe, you've covered most of it. Thankfully, it was a really comprehensive answer, but I think it's coming from the point of we put this in to understand how it was going to be used, and now we're at the process of if it was rolled out further, what would that look like? But given the usage in some locations has been quite challenging, we're looking to well, we've already started engagement with the company to provide Ask My GP to help us understand how is this used in bigger systems and what are the customizations and how can we make it much more appropriate for Shetland and the Shetland services that we've got and the way we've got our practice organised. So there's been lots of learning over the last few weeks, and we've got a programme of work with all the leads for the Health and Social Care Partnership, including my colleague Lisa, who's on the call today as well. And we're going to lead on some work to improve how we use Ask My GP across the places it is just now, and then roll out that improved version further. But there's a need to test this to do it well, because what we want to do is be able to turn it on and leave it on, and have it serve a purpose that's helpful for people as well as services.
Yeah, thanks, Tony. I think when we introduced it just before COVID, it was really meant for practices that had over 5,000 patients. So we're working with the company that made the software to be able to use it in a variety of locations, and clearly ones that have much fewer than 5,000 patients in them. But yeah, I'm a big fan of the system. I think it's really good, and I think the work that Tony and Joe and others are doing will ensure that it works better in future. The last question off my list, it says, why can't you send patients to other boards if Aberdeen can't cope? And again, I think that sort of touches on what we spoke about earlier, but it maybe goes a little bit further. Who wants to pick up that one? Kathleen? Kirsty. Oh, Kirsty's hand's up first. Oh, now nobody's hands up.
Sorry, Gary. I had forgotten to turn my mic on, so that's my fault.
Okay.
So yeah, I was just going to say that obviously we do use other health boards in Scotland for various treatments, but our main contract is with Aberdeen, and our teams work really closely together. So for example, in cancer care, a lot of the specialist chemotherapy and immune agents come from Aberdeen, and the teams work together and sit on the same multidisciplinary team meeting. So decision making is based with us working in that way. The other thing just to say is although Grampian are struggling, they are providing support to colleagues in NHS Highland and NHS Tayside who are equally struggling at the moment, and that is no different to NHS Lothian, Glasgow, Greater Glasgow and Clyde. And so when we look at our performance in the round, it's not that different to any other boards. So whilst, you know, absolutely it's not where any of us would like to see that performance, going out with Grampian won't necessarily fix that problem. And what we want to do is support colleagues in Grampian to, if we can, to make those services more streamlined. And we are in constant contact with them, as I know Scottish Government and colleagues from Tayside and other boards are. So where we can, we're absolutely trying to relieve the pressure. So I hope that's helpful. Don't know if Kathleen wants to add anything.
Yeah, on you go, Kathleen.
Thanks, Kirsty. It was just a small addition to say that because of those very close links that we've got with Grampian, as you described around cancer care, then it isn't as straightforward as sending a patient to somewhere else in the rest of the country, because we might be able to find a board that could do a treatment quicker, but then there's all of the pre and follow-up care that patient needs. So as Kirsty said, Scotland as a whole is under pressure. The north of Scotland has its own challenges. But there are also patient safety, clinical governance reasons why we're really trying to maintain those pathways with NHS Grampian.
Thanks, Kathleen. I think it's also important to note that we use the Golden Jubilee Hospital as well for quite a lot of procedures, particularly orthopaedic, hip and knee replacements and such like. And I guess we'll make more use as time goes on at the national treatment centres as well, as they start to come online.
We're in early conversations with what that might mean for us in respect of the Highland National Treatment Centre. So it may be that some patients who previously went to the Golden Jubilee will, from 2024, go to Highland instead. But we really need to make sure those pathways work, which is why, they certainly won't change, I would say, for the foreseeable 6 months. But yes, more will happen in the Northeast in the future. Yeah. Thanks, Kathleen. And we're still receiving really positive feedback about the Vanguard Theatre that we had a visit from as well, that took on some orthopaedic work. I've got Colin Marsland with his hand up, and then I think I'm going to have that look to the future after that. Colin.
The other impact on patients travel further afield is obviously the ability to travel off island. And obviously, as people know, Loganair is the main access for anyone travelling outside Aberdeen. And at present, we have very limited air flights to anywhere other than Aberdeen. And Aberdeen currently is the only location for those who are constrained about time off island that they can actually make day trips to. And obviously, currently with Loganair's flight schedule, it's a 3-day trip to either Aberdeen or Edinburgh if they're going to seek treatment down there, which we're aware of. The Golden Jubilee obviously benefits from a hotel attached to it, which patients can use in their stay, but that's not what the other hospitals in Glasgow and the Central Belt are built for, because they're built for around the patients' needs of the local community, which is about travelling there and back in a day.
Yeah, thanks, Colin. Right, I'm going to try and do a whistle-stop tour of what the future looks like for us. We always like to use the opportunity at our annual review to describe where we're going in the future and what our plans and priorities are. So we're currently in the process of developing some key plans to deliver our clinical and care strategy. Our strategic delivery plan will target improvement to areas likely to provide the most gain in sustainability and patient outcomes. These will include areas like urgent and unscheduled care, shifting the balance of care, programme initial agreement, that's the hospital programme that we've been speaking about, planned care and preventative care and proactive care. As we've said at previous reviews, we need to start to change how we provide these services to make us more sustainable in the long term. Also driving forward our direction of travel will be our digital strategy and delivery plan. The digital strategy will link the emerging digital enablement and innovation to deliver care in a different way. Examples of emerging technologies are things like the use of artificial intelligence to review medical imaging or automation to help support our services. Along with this, we need to consolidate the utility of the systems we have, draw on successes like Ask My GP that we discussed earlier, as well as other ways of accessing our services. We also need to focus on developing the digital literacy of not just our workforce, but also the population that we serve, so that we can move forward together in embracing new digital and innovative ways of working. We're renowned across Scotland for being a creative and innovative health board, and often are the first to embrace new and innovative ways of working because of our size and location. Staying with sustainability, we're also drawing on a sustainability plan, which will be linked to things like developing our workforce. We know it costs more to provide our services in an island context, and we need to be more open about that fact. We need to ensure any funding streams are aligned to making use of longer term, to make them sustainable in the longer term. We also need to highlight the nuances and associated costs of how we operate. Things like patient travel, costs of distant islands allowance, and the lack of accommodation in Shetland all need to be considered when we're discussing funding and why it costs more to provide services here. We're also reviewing our approach to being an anchor organisation and major stakeholder in Shetland. We are reviewing how our organisation contributes to the overall better future for our community in providing fair work, use of our facilities, and how we influence equity of access and care. We acknowledge that we don't just provide healthcare on mainland Shetland, and the challenges of providing equitable service and support to our islands with small populations is one that's foremost in our minds. We're also committed to completing our programme initial agreement to map out our services and required real estate for the future care provided by NHS Shetland and what this means for a replacement Gilbert Bain Hospital. Moving on to prevention. Finally, we need to really shift the paradigm around prevention and early action and proactive care. All of the things we've spoken about tonight are important, but we know that health services are only one small part of what shapes our health. We need to work in partnership with others in Shetland to challenge the avoidable unfair differences in health outcomes people experience. This means working on the building blocks of good health in their communities, as well as improving the services we provide. And it means being a good anchor institution, being a good employer, being a good member of our communities, and using our influence to make things better in Shetland. Prevention is a good thing for services. It means we'll be more sustainable and able to provide services within our funding allocation, but it is also the best thing for patients in our communities. It means things being fairer and people living in good health, not getting ill where it can be avoided, and getting early, effective support when it can't be avoided. Taking the prevention agenda seriously is the only way we'll be able to sustain services and tackle inequalities across our system. And moving on to working together, the changes and improvements that we make and plan are influenced by feedback from patients, communities and staff about how well our services are working, as well as being informed by how well we are doing against targets for performance and our finances. To help us come up with the right solutions that work for Shetland, we're always looking for more feedback and input and engagement from patients and communities. These are some of the results from recent community engagement undertaken as part of the initial agreement programme. This is just one snapshot, but as you'll hopefully have seen from the review tonight, all of these areas are on our radar. Getting feedback is really helpful for teams, both for learning and making things better, and to celebrate where they are doing a good job, as we know our teams work extremely hard. One of the ways that you can get involved is by letting us know about any experiences you've had on Care Opinion, a really fast, easy way to share feedback online. Known teams and managers will see it. Go to careopinion.org.uk to tell your story, or by coming along to any of our events or engagement sessions. You can also get involved by getting in touch through our website. On the homepage is a link called Investing in the Future, which provides details of how to contact us. Investing in the Future, NHS Shetland. We're also working closely with our colleagues in the community planning team in Shetland Islands Council and our public health team to work with communities and to understand their needs and how to meet them better. As well as the Care Opinion, we've got the feedback and complaints section on the NHS Shetland website that you can make use of. Do we have any last questions or comments? A few minutes left in this session. I'm not seeing any hands going up. I know we've got one or two journalists with us tonight. Have you got anything that we haven't covered that you'd like us to pick up? No?
No, you answered my question at the beginning, so thanks for that, Gary.
Okay, no problem. Okay, before I close the meeting, Brian, do you have any final thoughts?
No, I think it's been a really good session, sort of just outlining just where we're at, how we're performing over the last financial year, and really more importantly the challenges that lie ahead, but also how we're engaged with redefining our future and trying to remain being that innovative kind of health board that we're renowned for. I think you touched maybe just on your last slide. I think one important thing is how hard our staff are working. How hard they have worked over the last 3 years, how committed they are to the community that they serve, and how it is our staff that make NHS Shetland the success and the performance that we've got. So I think just on behalf of us both, Gary, just to openly acknowledge and thank our staff for the efforts that they put into making our organisation such a success.
Yeah, thanks, Brian. I would very much echo that, and I think the NHS Shetland is one of those organisations that if any one person was missing out to it, their absence is felt. It needs everyone for the organisation as a whole to be able to work as it does. So the staff really are our most important asset. Okay, I don't see any more hands going up, and I think we are just pretty much on time. So I just want to close by thanking everybody for taking the time to attend this evening. We know everybody has busy lives, so it's good to see so many people engaging in this tonight, and especially those that came along armed with questions. As ever, though, if anything comes to you outside of this session, then please do get in touch with us, and we will endeavour to get the answers to whatever question you might have for us. So thanks very much, everybody.